Well, good morning. Thank you very much indeed for coming today. I just thinking about what you've been doing and the importance of INFACT in the way that the service is run, the way that you relate to patients and others. And just thinking that the organisation was launched in 2012, I think, and the purpose was to support families with children whose disabilities were caused by their mothers taking anticonvulsant medication through pregnancy. And I have to say, we've heard through other sources that this support is so highly valued, and thank you for that. And of course, you also raise awareness with the government and other agencies, and you supply the Secretariat for the All-Party Parliamentary Group, again, which I know is highly valued. In addition, of course, you run the Association for Families, and you've got over 700 families in membership, which is very impressive. In the November oral hearing, you covered a number of important themes and what you hope for the future. And you kept us very fully informed of your concerns with the MHRA, with the yellow card system, the lack in the past of patient involvement, how the pregnancy register could be improved, and the personal independence payment and the way it's sometimes denied to people who previously benefited. And of course, that all of that is so important, and there's a lot more as well. But perhaps the most crucial of all is the pregnancy prevention program and how it is not comprehensively working. So I know also you've conducted surveys which have been helpful to us, and the case studies that you have supplied. And I have to say they are heart-rending, and thank you for that. Today, though, is different from the first oral hearing. This oral hearing is your opportunity to tell us what you found in the intervening period, because the first oral hearing was in November, and so we're 5 months on from now. And in the intervening period, there's been a lot of information that's been coming through and a lot of views that people have expressed. So it's up to you now to tell us what particular issues you would like us to consider when writing our report to the Secretary of State. If we could start, if you could just say who you are and your position with INFACT.
Okay, I'm Emma Murphy and I'm Managing Director of INFACT, and I've got 5 affected children by valproate.
I'm Janet Willaims, I'm CEO of INFACT and FACTA, and I've got 2 adults affected children.
Thank you very much. So now it's really over to you, whatever you want to tell us.
Okay, so we've watched all the previous oral submissions, and we have taken minutes of everything, and we would like to respond today to that. So in our last submission, we explained that at present we have approximately 2,000 people on the database who have been affected physically and or mentally by valproate, the majority of which have neurodevelopmental disorders and are on the autistic spectrum with poor speech, memory and understanding. A large number of these children are now over the age of 20 years old and continue to require a huge amount of support from their parents. The excessive stress that valproate sufferers experience to understand the outside world and the circumstances of their actions in many cases has caused mental problems such as anxiety, depression and seizures. Since that submission, we have attended many meetings with the MHRA, Department of Health, General Pharmaceutical Council, the Royal Pharmaceutical Society, with the conclusions have been a very mixed bag of understanding what the pregnancy prevention programme means, clear instruction given from it and what can be done to ensure the new warnings are given. Almost 12 months from the introduction of the PPP, we still find that some women are not receiving the warnings, whether it be from their pharmacist, GP or specialist. Some have still not been called in to see their GP or epilepsy nurse to discuss the topic, and all this showed in our survey which we presented to the MHRA in February. We have also carefully watched and noted the evidence given to the review team from NHS England, the GMC, the CQC, MHRA, NICE, the General Pharmaceutical Council and NHS resolutions, during which we recognise a number of points we would like to make today. Firstly, on the 28th of January, evidence was given by the Royal Pharmaceutical Society where it was stated that, and I quote, "This has been communicated but most probably not passed down the line or possibility of it being forgotten about due to cards and booklets left elsewhere in the pharmacy. This alone is unacceptable, as we know since April 2018 and the introduction of the PPP, we have been contacted by at least 6 women who have become pregnant on valproate due to not receiving the information supplied through their pharmacist. We believe a pharmacy should have a set procedure which should be robustly followed, especially when legislation has been changed to ensure women receive the information." The RPS went on to say in the evidence that not all pharmacists are a member of the professional body. Only half are on the register, so not everyone received up-to-date information. There are warning labels that go on the box. The pharmacist would look at them, assess if there is anything that needs to be done, and the valproate warning label would act as a prompt to have that conversation. However, INFACT are aware that this is not the case. Warning labels, in some circumstances, fail to be put on all white boxes, and so the pharmacist or pharmacy technician fails to have that discussion. We are, however, aware that in a couple of areas the new Sanofi boxes are coming through, where there is only 28 tablets in a box in order to eradicate using the white chemist boxes eventually, although we are unsure as to how long it will take for the new boxes to become the norm in all areas within the UK. At our last MHRA VSN meeting, which the Royal Pharmaceutical Society attended, it was explained by them that the dispensing technician was not able to give instructions to patients when dispensing, and that only a dispensing pharmacist was able to do so. Further information was sought, and we found, according to NHS Health Education England, the difference being that a pharmacy technician prepares medicines and other healthcare products and supply them to patients. They also take an active role in providing patients with guidance on taking medicines. We have since met with the CEO and Registrar of the General Pharmaceutical Council, who also gave evidence to discuss valproate, and the understanding is that a pharmacy technician was able to give the warnings and that they were aware that every pharmacist had received the new PPP information on valproate. However, in his evidence to you, he stated that the difference between what standard procedures is to something that happens that afternoon is that things don't happen the same way on a day-to-day basis. Although we understand his explanation, the routine a pharmacist has when communication and dispensing a prescription should be written in concrete and not rest on the day-to-day events. The GPC was very accommodating and has offered to involve INFACT, and we look forward to working with them in the future. NHS England's evidence we found very sparse and protective of those he was aware had failed women in the past by not informing them of the dangers. For example, on a number of occasions he said we should take stock. When asked who should take stock, he answered by saying, "That's a good question," implying that even though he had said it, he had no answer as to who should do it. He went on to say, the regulator, MHRA, have put in place the PPP, and in the light of that, they would expect healthcare professionals to react accordingly. As for pharmacists, the GPC have done everything right. I look at IT systems and flagging, and they have reacted appropriately. Community pharmacist systems ditto. I just wonder if there is more to do. At no point was it mentioned about how the GP or the pharmacists had failed women on the delivery of the PPP, the reasons why this may have happened and what could be done to correct it. On the 23rd of January, the review team also met with Professor Helen Stokes-Lampard, from the Royal College of GPs, and we were very concerned by some of their comments. Although we understand one or two things will be different to deal with due to the current system, some of the comments were not true to life as to what is actually happening during visits to your GP. For example, the RCGP is committed to patient safety and care, developing long-term relationships with our patients. Number 2, good practice states anybody on long-term medication should be having an annual review of their medication. Number 3, we have a quality outcomes framework that came into effect in 2004. Epilepsy is one of the conditions that is there. Number 4, if a patient came in and says, I think my child may have an abnormality related to a drug I took in my pregnancy, a GP knows right away that is definitely specialist care. Number 5, when in medical school, we were all taught pregnancy and epilepsy drugs don't go together. We are aware through our own experiences and that of our families that due to the struggles of getting an appointment with the same clinician repeatedly is near impossible, that 8 out of 10 patients are never called in for annual reviews. The Quality Outcomes Framework from 2004 was withdrawn around 2014, which left female epilepsy patients with no chance of preconception counselling. It's only recently that a new quality incentivised framework is to be introduced. However, INFACT find this insulting that GPs and specialists have to be incentivised before they can give particular warnings to their patients, which comes under their job description, as they have a duty of care towards their patients to do the task. We are all aware too that a GP would not respond particularly well to a patient who insists that their child has been affected by a drug which they had prescribed, and the specialist referral, which should be genetics at this point, is usually avoided by the GP in many circumstances. Our biggest shock was at a comment made by the professor when she stated that while in medical school they were taught that epilepsy drugs and pregnancy did not go together. Of course, we are not sure how long ago that was, but this makes the point that GPs were taught about this problem many years ago, yet still went on to ignore the problem and failed to warn their female patients without having to be literally forced to do so. How many other GPs and specialists have the belief that the professor has, yet still to this day, with the PPP in place, continue to fail to inform? Or were they instructed to ignore this fact by the Department of Health, bearing in mind, as in our original submission, we stated about the archive documents of 1973 from the Committee of Safety of Medicines? NHS improvement evidence was very much the same when it came to patient safety, as they explained how complex the system is when it comes to a patient making a complaint about their treatment, stating that the system is somewhat administrative and bureaucratic. However, when asked about why does the system keep changing, he stated that he thought it was due to the political interest the NHS received and people thinking they could do better and not giving things time to have the impact. But from our understanding of the system through the archive documents, we feel that constant change may well be to save money and cover up the truth about a penniless system and the bad decisions it's made. He went on to say that he agreed with how the serious incident framework hadn't been universally successful and that there will be a new serious incident safety framework. However, it wouldn't be called that, but only a few moments earlier he stated that he felt change wasn't good, which again seemed a little contradictory. He stated that NHS Improvement had put guidance out to the prescriber concerning valproate in 2017. However, they play no part in the monitoring of the drug, as it is not in their remit to do so, with the MHRA dealing with licensing and monitoring and NICE dealing with the guidance. However, on their website there are study reports into diabetes and pregnancy and smoke-free pregnancies, but nothing whatsoever on epilepsy and pregnancy. We did, however, do a search to find supporting the safety of girls and women being treated with valproate, even though this was 2 years old and published before the new PPP was introduced. We noticed while listening to the evidence given by Sanofi that they interact with patient groups. However, on the 12th of October, INFACT received an email from Sanofi as we have queried information which had come through our sources about the shortage of Epilim at that time. In that response, we were told that Sanofi had changed their internal processes to ensure patient groups were informed as soon as possible about medication shortages. We are unsure, however, as to who those patient groups are, as INFACT nor FACTA has never been informed of the Epilim shortages since the date of the email, even though we are aware this has been happening. Sanofi also mentioned to you about the quick response or QR codes now on patient information leaflets, which would give patient access to patient information materials. However, the majority of patients would not be aware or familiar with this. We know that in their evidence they showed you the smaller Epilim boxes, which only holds 30 tablets and would ensure all patients receive the warning on the box. This is something we do applaud and have asked for quite some time. However, these smaller boxes still haven't reached all pharmacists as yet, and the pictogram on the boxes, which have been there since 2015, took around 12 months to get through to patients due to the backlog of old Sanofi boxes which did not hold the warnings. This is a process which very much needs to be speeded up to ensure the safety of all patients and their offspring. Sanofi also talked about messages getting out since 2015 following the Pharmacovigilance Risk Assessment Committee, PRAC. They noted there was a lot of discussion through the patient groups with the MHRA, and in turn the MHRA with Sanofi sent out concerning pharmacy messages, and as for the patient guide, they stated there wasn't a delay in getting these packs out to people. We had the final wording from the PRAC in February 2015 and were asked to come up with something more attractive than a sheet of paper, so the patient guides were submitted to MHRA. Stating they worked with stakeholders, namely patient groups, on these materials. However, this process took way too long to finalise, with endless meetings with the MHRA and other groups, with the process becoming too diluted, taking almost 4 years to complete. During this time, approximately 1,600 children have been affected by valproate in pregnancy, with the drug prescribed to approximately 28,000 women of childbearing age a year at that time. We understand there is always procedures to follow. However, during our early talks with MHRA back in 2013, INFACT produced our own booklet for women which explained the complications when taking AEDs in pregnancy and which was given to the pharmacovigilance team at that time. It was then in October 2013 that conversation with the EMA began, and again it has taken 7 years from that initial discussion to reach a finalised patient booklet to be released.
The past work completed by INFACT, for example the PPP survey, shows that approximately 40% of women never received a patient information leaflet inside a white chemist box, 78% have never received a small pharmacy card, and over 60% have never asked to sign the acknowledgement of risk form by their GP. Some women are still waiting for an appointment with their neurologist in order to change the medication, although we are aware that the system has changed somewhat when it comes to these appointments, with many women now not actually seeing a neurologist but an epilepsy specialist nursed in their place. Some have struggled making an appointment with their GP or epilepsy nurse to discuss the possibility of becoming pregnant while taking valproate due to the sheer lack of appointments available, another area which the Department of Health and NHS England need to consider funding for in able to correct this. Although all those concerned with the PPP are aware of the NICE guidelines, we are not surprised by the evidence they give to the review team when questioned about the procedures of and that of valproate. Their Deputy Chief Executive stated, guidelines are reserved for broad recommendations, not mandatory, but doctors are expected to take them into account. If guidelines are not being followed, NICE have no powers to make them happen. NICE issue recommendations as to where research is needed but can't commission it. Although we understand NICE work hard to put together new guidelines on numerous medications, etc., it's important to pay particular attention to the areas that they have no control over and find ways to ensure the guidelines are followed by healthcare professionals in order to avoid patients' lack of communication and understanding for their illness or prescription medications and the danger of them. However, on the 28th of March we received an email from the MHRA stating and giving the link to the NICE guidelines for valproate and other AEDs which have been released. This new guidance, however, is very contradictory, stating sodium valproate as first-line treatment to children, young people and adults with newly diagnosed juvenile myoclonic epilepsy unless it is unsuitable, and to follow the MHRA advice on sodium valproate. Consider lamotrigine, levetiracetam and topiramate if sodium valproate is unsuitable and not tolerated. Be aware that topiramate has a less favourable side effect profile than lamotrigine and levetiracetam and sodium valproate, and that lamotrigine may exacerbate myoclonic seizures. Follow the MHRA advice on sodium valproate. However, further down the guidance it goes on to state, discuss with women and girls of childbearing potential, including young girls who are likely to need treatment into their childbearing years, and the parents and carers, if appropriate, to risk of AEDs causing malformations and possible neurodevelopmental impairments in the unborn child. Assess the risk and benefits of treatment with individual drugs. There are limited data on the risk to the unborn child associated with the newer drugs. Specifically, discuss the risks of continued use of sodium valproate to the unborn child, being aware that higher doses of sodium valproate, or more than 800 milligrams a day, and polytherapy, particularly with sodium valproate, are associated with greater risk. Follow the MHRA advice on sodium valproate. Although the above states that the danger of sodium valproate in pregnancy, the first comments above it on the subject of AEDs do not, and so any doctors most probably would not go down to read all the guidance on the AEDs due to the lack of time they have in appointments. Due to this ongoing review into valproate in pregnancy, we find the above an insult to the work completed at present and feel it's necessary for NICE to meet and to review the wording and positioning on the statements, as they've given rise to contradictory and confusing guidance when prescribing valproate to women and young girls. Therefore, in some circumstances, doctors may feel they have every right to continue to prescribe valproate without consulting or explaining the possibilities to their female patients. The question is, why GPs are still not getting the word out to their patients, and why pharmacists are still not using the warnings when dispensing the white chemist box. We heard also through the review submissions that the founder of the UK Epilepsy Pregnancy and Register in March, and applaud the way in which he explained the system as he sees it, with the honesty as to his feelings on other AEDs in pregnancy, saying that he felt we would have to come back and be in the same situation in 5 or 10 years' time. One of the questions he asked was, how did we miss this? The answer to that question can be answered by the evidence INFACT put forward from the archive findings, and that is that clinicians hadn't missed it, but the newer clinicians simply hadn't been informed by the Department of Health of this devastation. Dr. Morrow also noted that the yellow card scheme doesn't work, something we would tend to agree with, especially when 50 years on it still fails to be used fully by clinicians, and that most of the reports now are completed by the patients themselves. Through all the evidence given by each governing body, the lack of ambition shown by each of them to follow legislation and ensure the PPP was in place for every woman prescribed valproate was very poor, and it worries us as to how the halting valproate affected children will ever be achieved other than a complete ban on its use by women, although as we understand this is not something that everybody wants. Since INFACT's last submission, we have worked with Lord Shaughnessy following his departure from the ministerial post, and was very pleased when he suggested a debate in the House of Lords. During his opening speech, Lord Shaughnessy stated that there is an tension between innovation and safety, and that the principal idea that he wished to explore today, and to how to balance that risk and encourage innovation, especially for those most in need of hope and help, but also act faster and be more agile, more compassionate when things go wrong. With valproate, this has been a continuous ongoing battle for families of those affected, with more risk than benefit towards women of childbearing potential and their offspring. Even with the introduction of the PPP, the resistance to carry out the legal instructions has continued within the medical profession of pharmacists, with the need now more than ever for the MHRA to step up to the mark and look at other avenues, such as maybe reclassification of valproate to Class C. With this circumstance, as with pregabalin and gabapentin, it would make it illegal to supply valproate through a repeat prescription scheme, hence the GP having to have a face-to-face appointment each time a prescription is required by that patient. This may well create complications on the doctor's workload. However, it would be encouraging GPs and specialists to ensure the PPP conversation is carried out and a change of medication is completed where possible. As with the new guidelines for sepsis, hospitals are now have to face financial penalties for failing to meet guidelines, and this too is a necessary amendment. We are aware that the steps required are something which the government has been considering for some time, with the introduction of the long-term plan setting out two clear areas for the further progress on care, quality and outcomes. Firstly, enabling a strong start in life for children and young people, and secondly, providing better care for major health conditions. This will improve safety recognition of deficiency and the collecting of linking of data, and as noted by Professor Willett in his evidence to the review, as commitment to start to move on that process in the long-term plan, which is intended to start in 2020. INFACT have stated for a long time now that services need to work together to ensure information about women and their medications filtered down from one department to another, through NHS social services and education. However, this has proved difficult over the years, with all three services refusing and finding reasons why this would be untenable in their eyes. As with the long-term plan, we hope this will be a factor that the patients and children affected by these medications are spotted and treated quicker, therefore stopping any possibility of them falling through the net. However, in the long-term plan it states, over the next 3 years, autism diagnosis will be included alongside work with children and young people's mental health services to test and implement the most effective ways of reducing waiting times for specialists. We are all aware of the staff shortages for specialist services and expect the government to have implemented the employment of extra specialist staff to take the burden and to ensure that this happens. The plan goes on to state, as set out in Chapter 1, local areas will design and implement models of care that are age appropriate, closer to home and bringing together physical and mental health services. These models will support health development by providing holistic care across local authority and NHS services, including primary care, community services, speech and language therapy, school nursing, oral health, acute and specialist services. There is nothing more as a parent you would like for your disabled child but to have these services on your doorstep, as we once did with the child development units and the Sure Start scheme. However, we all know that even though this sounds an exciting era in theory, it's up to the government to ensure the funding is secure and the staff is available to make these recommendations happen. As in the late 80s and early 90s, most children with special needs with a diagnosed condition from birth were put through a child development unit and seen by a number of specialists ranging from paediatrician, occupational therapist, speech and language therapist, physio and social services. However, that scheme was fizzled out and at the end of the 90s, and we are now finding that specialist services are few and far between, with only 2 or 3 speech and language units in the whole of Greater Manchester. It is going to be a hard line to follow to ensure children with a condition such as FVS are taken care of with the lack of services and funding as it stands. Due to our involvement with families where diagnosis has been difficult, we know that many have sought a private appointment where assessments and advice have been of a better standard. However, these families, when going armed with a diagnosis to education, find that it's refused due to it not being through NHS England, and so once again finding themselves fighting for support. As we mentioned in our last oral submission, through the archived documents uncovered by INFACT in 2015, which date back to 1971, and medical research papers dating back to 1981 for valproate, we are fully aware that the issue of fetal valproate spectrum disorder, which is to be the new term of the condition, is not the doing of the NHS and its specialists and GPs, but that of MHRA and the Department of Health in their refusal to all women taking the drugs being made aware of the dangers in the first instance. Some may say that it was a paternalistic view at that time. However, as with the PPP, this continues to take place. We understand the concerns doctors must have when explaining the dangers of taking sodium valproate to female patients and the fear of the patient stopping a medication to avoid any effects on the fetus. Recently released by the British Pregnancy Advisory Service was a briefing called Sodium Valproate and Women with Epilepsy, which lies out the figures of women from 2013 who have died as a result of stopping medication during or after the pregnancy. The information is a sad reminder of how dangerous epilepsy can be without the correct counselling and guidance. It read, in 2017 National Maternal, Newborn and Infant Clinical Outcome Review Programme report on the surveillance of investigation of maternal deaths found that between 2013 and 15, 8 women with epilepsy died during pregnancy or in the intermediate postpartum period, and there was only 1 additional pregnancy-related death between 6 weeks and 1 year after delivery. In 2014, a report where epilepsy was also covered in depth, 5 of the 9 women whose deaths were considered had stopped their AED and were not taking any medication during pregnancy. Of these, 2 had previously been taking sodium valproate. This compares to the 2014 report where only 2 out of 14 epileptic women who died were not taking any medication. Some reports found that in only 4% of women with severe morbidity from epilepsy received good maternal care. These figures of those children disabled physically or mentally as a result of valproate taken in pregnancy and confirmed by the MHRA are overwhelmingly high in comparison. From 2013 to 2015, there were 1,200 babies harmed by valproate in the womb, and in 2017 a further 400, bringing the total to 1,600 babies harmed in the space of a 4-year period, and also a stark reminder as to how potent valproate is to the unborn child. In some ways, valproate can be compared to thalidomide. However, the difference is a very stark in comparison with the physical problems you see the thalidomide victims suffer. Valproate in many cases remains invisible, with many disabilities being of a mental nature such as autism, learning difficulties, memory problems and more. Many of the adult valproate victims have exceptional needs, with many of them not realising they do. or what those needs are, and completing a DLA form or PIP form saying that they do things when they can't in order to please the assessor. For example, using a microwave, which physically they can. Circumstances, this may seem impossible to the assessor, but mentally it's not, as many would forget they have to put the item in and forget to take it out, and not eating due to a distraction. Taking medication is another problem with the benefit system. These people may look capable and competent to remember their medications, but explanation why it's needed and when you take it is a must. FES people can walk, but they are unable to use transport alone due to memory and distraction or confusion, and because of this are missing out on so much. The responsibility for the number of children harmed lies solely at the door of the government for creating this monster of a cover-up and allowing thousands of children's lives to be ruined in the process. All the evidence shows that valproate has caused so much damage over its lifetime, with the damage suffered by those exposed, many of which have suffered lifelong disabilities for over 40 years. We are all aware of the problem also with the benefit system and the stress and pressure these families and their affected children go through every 3 years when the dreaded form comes through the letterbox. Since the personal independent payment was introduced, the forms themselves have become a little smaller than that of the DLA form. However, the methods of assessment and what PIP should be granted for is somewhat more distressing than it was. A person over the age of 18 who was once in receipt of PIP indefinitely has had that taken away and is forced to reapply for PIP. So immediately the worry of the family begins, as they now have to prove that their son or daughter is incapable of caring for themselves or getting themselves around outdoors again. The one thing which isn't borne in mind or asked about on the form is whether the problems or diagnosis which a person has is lifelong, and throughout the assessment particular tests are supposed to be carried out for memory, speech and physical ability, although not all assessors do these tests on every assessment. The fear of the family when he's waiting for the results, and the many found that either their explanation of the problems have been misinterpreted or not being sufficient for them to be in receipt of the care component. We are finding that many people with epilepsy are being awarded mobility because they are unable to drive, yet being refused a care component simply because they have said that they can put something in a microwave, with no thought of a person with epilepsy suffering a seizure or taking a hot substance out once it's heated. For a child or person with fetal valproate spectrum disorder, it's very difficult to process them to go through, as many of them on view looks physically capable. However, having FES and autism brings invisible problems which are lifelong and will never be controlled by medication or therapy. This must be borne in mind by the DWP when dealing with a person with FES, and once awarded, given for life or an indefinite period of 10 years, so the family doesn't continuously find themselves fighting the system for support that they are entitled to. So during your summing up, we ask you to consider the above and the many children affected, those especially who are now into the 20s, 30s and 40s, and the amount of pain and suffering they and their families have endured as a result of the devastating effects of this medication. Let's also remember the many families who have experienced loss as a result of valproate in pregnancy. The death of a child is unbearable ask for any family, so it's important that you consider them too. It would be a terrible injustice to make these people suffer a moment longer, and a moral conclusion to all the unnecessary pain and suffering is now necessary. So to summarise, when making your recommendations, we ask you to consider a guaranteed future for children affected, ensuring diagnosis, for their education purposes, ensuring that teachers and tutors are taught neurodevelopmental problems caused by valproate when studying, that the present geneticists train the new generation to ensure the diagnosis and constant knowledge of FVS, and that medical students in all areas are taught about valproate in pregnancy and the symptoms of the condition. The future planning make it easier to replicate guidelines, to forge a pathway for other AEDs in pregnancy, and to ensure NICE follow strict instructions on valproate when it comes to guidance. That the funding to allow the form of a diagnostic clinic is ring-fenced so as to stop any government withdrawal. That the benefit system recognises fetal valproate spectrum disorder or FVS for benefits such as employment and support and PIP, awarding the funding for life in these circumstances. That a respectable care plan is offered to those affected to support them through their lifetime, allowing them a mortgage or a sustainable life, and that a lump sum is given for their previous pain and suffering, and that families experience bereavement due to valproate exposure receive a posthumous payment.
Thank you very much indeed. That was extremely useful, very comprehensive, very powerful. So thank you both very much for that. And not only are you very professional in the way that you research this and you speak all over the world, when you've been to New Zealand and other countries. But I think the way that you approach it is, as I say, very professional, and we're grateful for that. Can I pick up just one thing that Emma, you were talking about, and it concerns the Royal College of GPs. And you were saying one of the problems was that the quality framework in the past had been withdrawn, but they are now going to produce a new one. Have we got a date for that? Has it been published, or are we still waiting for it? Or we can go to them and ask them.
Yeah, well, there wasn't a direct date given as we are aware. It was supposed to be put in place as soon as possible to ensure that the PPP was used, but there was no definite date on that.
Right.
And that was discussed at the valproate stakeholder network group.
Yes.
But no date.
No date, yeah. Well, we can always go back to them, because I think that would be useful to have that from the GPs. The other thing I just wanted to mention was about PIP, to say that we are meeting the Department of Work and Pensions to actually discuss this and go through it. So all the time we are still listening, and we are picking up points like you've made today, and especially you're summing up the particular things you want to see. And we're listening to all of that, and in the meantime we're still talking to other agencies and putting the points to them. And today, certainly, where you have mentioned certain agencies, organisations, we will be taking that up with them to see if there is a response from them on that. But then, of course, it's their choice whether they want to come back to us or not. So I'm going to ask my colleagues if they have any questions, things they'd like to say.
You very powerfully made the point of the gap that you've identified between what the system has promised or what the professions are promising and the reality of what you are measuring now. Your members are drawing your attention to. It would be very helpful to have a table of that, if that's possible, for our purpose. Would that be possible?
Yeah.
Yes.
And the other thing you drew attention to, which I hadn't realised, this is the hospital where child development units were first introduced by a man called Dr. So the notion that that service is no longer available for children with development needs, do you have chapter and verse on that? Because I didn't realise that.
And the majority of child development units did come to its conclusion sort of around about the 90s, because I mean both my sons went through the child development unit, seen by many surgeons in one particular place.
Right, was the idea.
Yeah, and then obviously the Sure Start came along as well, and then that was completed too. So at the moment,
I mean, I knew children's centres funding had been diminished, but I didn't know the child development units no longer exist.
Well, you've not.
There's certainly one still here or at St Thomas's.
I've never gone to a child development unit, and mine are all at the younger end
Right, yes.
now.
I remember them very well, and in fact
Yeah.
in our area it was social care that were doing it, and they had a number of professionals involved,
Yeah.
and they were highly, highly valued
Yes.
by the parents who were talking to these wide range of professionals there. And I remember them going, and you know, the cry of despair from people who had used them. But as you say, I think the idea was that they would be taken up with other agencies, taken up with other organisations. But I'm not sure there's anything as comprehensive now within the community.
It was very much a medical thing, though, because that was the idea that rather than having to take your child to see an ophthalmologist or ENT specialist or an orthopaedic surgeon or paediatric neurologist, they would be in one place and together as a multidisciplinary team assess the needs and plan the care of your child. So I need to look
Everything
into this.
seems to be done sort of separately now.
Yeah.
I mean, your GP will refer you on to a paediatrician or whichever specialist that you need, but there's no actual particular multidisciplinary team as there used to be.
We'll look into it, thank you.
And it did include social care.
Of course it did, yes.
Right, Simon.
Yes, thank you both very much. It's really helpful. As others have said, very powerful. One of the things I was just going to ask about was the contradiction you highlighted in the latest NICE guidance. Have you discussed, because you've said to us quite understandably that you want NICE to clarify.
Yes.
Have you discussed that with NICE?
Yes, we have. I'm glad you brought that up, Simon, actually, yes, we have. We've met with the MHRA and NICE, and that is being corrected.
They are going to correct it?
Yes.
Do we know how they're going to go about that? Do you know how they're going to go about it?
Well, it's a matter of sort of updating the updates.
Yeah.
Right.
And
They're going to correct it in a way that you'd be comfortable with? Is that
yes,
your understanding?
they've gone through how they're going to do that and what sort of wordings that they're willing to use, which has been agreed.
Do you know when?
In around about 3 months' time, hopefully.
They were suggesting maybe a year. We didn't find that helpful in any way. So they have agreed 3 months.
Yeah.
Okay. The other thing I was just going to ask about was you raised this point about pharmacy technicians and whether they can provide warnings verbally to patients when at the point of dispensing, and the apparent difference between what the Royal Pharmaceutical Society said and what the GPHC told you. Has that been resolved, that difference between those two organisations? Or is that still a...
That's still an ongoing issue. Yeah, I mean, we met with the General Pharmaceutical, well, we've met with them a few times now, General Pharmaceutical Council, and in the first meeting that we had with them, they said that really shouldn't be an issue. Whoever hands over or dispenses the medication to the patient should be able to give that information to them, and it shouldn't really be a problem.
Sorry, the GPHC agreed with you there, right?
Yeah.
It might be something we follow.
Yes, I was going to say agreement
I was going to
is...
send something out. I was going to send out.
Yeah, they did say they were going to send an update round following that meeting, and they would put more information out just to bump it up and encourage.
Yeah, I mean, agreement's terrific to have reached that. It's then the implementation that is
Yes, of
actually
course,
the challenge, always, isn't it?
Yes, I do have one question. I mean, you've been very active in monitoring what's been happening with the pregnancy prevention programme, and the work's been fantastic. And you talked about maybe what is needed if you can't deliver this is the short, sharp shock, which says actually you withdraw it.
Yeah.
But that the community is divided, because the
Yes, it
alternative
is.
would be reclassified, and therefore that prevents renewed prescriptions automatically. It has to be done with a review.
Yeah.
How divided are the community? How divided are...
Well, the one thing we don't want on this is a ban. We've never wanted that. We don't want that at all. However, we've pushed as far as we can go now with this. And other than a reclassification, I think from there onwards the next step would be to look at you know, you have got a small minority of people that are always going to need this drug, that have tried everything else and that nothing else works for them, and that's why we don't want the ban. But to do the reclassification, that would be our way of finding out which people haven't tried a drug, which people can use other medications other than valproate, and finding that small percentage.
The irreducible minimum.
Yeah, yeah.
I mean, it's interesting because I know that you had concerns about that because it's not convenient, for example,
Of course,
to have
yeah.
to go to a
Yeah.
hospital or whatever to get that
No, of course.
prescribed for you. And are you feeling that that might be an acceptable compromise if
Well-
you really can't make this work any better?
It's acceptable compromise. There's nothing else left to try.
We've tried everything, and like Janet said, we've pushed and pushed the regulators, everybody. We've met with absolutely everybody, and they all have an excuse, a different excuse, and I think it needs some sharp shot. We don't want that, but we've got to safeguard these babies.
The only other alternative would be, and it's like we had this discussion with the GMC, and if you've got a doctor that's prescribing but not passing on the PPP and not asking women to sign the acknowledgement of risk form, then it's all right for that doctor to do it once. It could be another surgery down the road where it's happening with another doctor, and it's looking at that area rather than just the one surgery that the GMC don't seem to be taking on board. It's all right one doctor doing it in one surgery, but if you've got 10 in that area, then that's 10 doctors not passing on the information, 10 women not getting it. We've already got 6 women that have become pregnant since the PPP came out. So,
Are the women that have become pregnant since the PPP, are they in one geographical area?
no, they're not.
Are they all
No,
over?
scattered,
So it
fortunately.
looks-
Yeah.
So there's an issue about spreading good practice.
Yeah.
Definitely.
They must have networks and things that, well, Cyril knows an awful lot about primary care, but I think that they could, at their meetings, local medical committees, whatever.
Well, we would hope.
Yeah.
Well, we do hope that, but it doesn't seem to be happening.
No.
When we met recently, we discussed the issue of every woman of childbearing age being on a register, which we could, with their permission, obtain from the prescribing of the medicines perhaps. And that would then mean that they could directly take responsibility and be contacted. Do you still think that's...
Yeah.
Yeah.
Yeah, I mean, we've discussed this before, and I think, like with the UK Pregnancy Register, for example, there needs to be something, like, you get a letter when you need your smear test done, you get a letter when you're due to go and have your mammogram, say, for example, so why can't you do it for this?
Because modern medicine is very complex, and
You know.
somehow putting the patient more in charge of their own destiny is perhaps a different way, rather than just relying on the system and the professional.
It's all about getting the information out there, Cyril, and it's just not filtering through. So it's a case of finding out the reasons why that information isn't filtering through. There's got to be a reason as to why the doctors and the pharmacists are not doing this, other than just saying, oh well, you know, at the back end of the day sometimes you don't do it because you've had a long day or whatever. You can't do that with this.
Systems are complicated and they
I
depend on
understand
people, and sometimes the people are not wanting to do a good job. I can't imagine anybody does the job without wanting to do a good job.
Do you think with new technologies coming in, communication systems and like that we could harness them in a much more productive way for particularly the people that you represent?
What do you mean, as in?
Well, with GPs, for instance, we know that one of the things that they have are the alerts. And one of the problems with the alerts is that they have too many. And
Yes, I
so
understand
that's
that,
a bit
yeah.
difficult. But I was just thinking, when Cyril was talking about women having their own notes, a bit more control over their destiny and their families and the rest of it. Do you not think that, well, I'm just thinking we've got a Secretary of State at the moment who is very keen on new
The digital
technologies.
area, yes.
And you know how we can harness that to the benefit of the people you represent.
I think at the moment we've got to try everything,
Yes.
absolutely everything, and we would encourage anything at the moment.
Yes.
Yeah. The one problem you may have with that is that valproate can, well, all these AEDs can affect thought process and short-term memory. I mean, we come across that all the time. So if you're going to put it in the hands of the patient, that you may have one or two that
Remind me how
struggle
many
with that.
women there are of childbearing age taking with epilepsy.
The last time we spoke to the MHRA, it was about 21,000.
How many?
21,000.
So a database, 21,000 people who, with their permission, is accessible by email or Facebook or on Twitter. If an organisation like INFACT had access to that, you could do a lot.
Yeah,
Yeah,
very lot.
definitely. And we do our utmost to make
Yeah.
sure it was done too.
Definitely.
Right, okay.
But there you go.
Is there anything else that you would like to say before we draw this to a close?
That's everything with regards to this, but we want to thank you as a review for hearing all our voices. It's been 40 years too late, but we really thank and applaud all the work you've done because it has been needed, and a lot of our parents are overcome that this is happening.
Yeah.
Thank you so
That's
much.
very generous, thank you.
Thank you.
And can I say, I do think the amount of work you put in, as you say, you meet so many people, and at the same time you have to care for your families. And I think it's hugely impressive. Thank
Without the husbands, we couldn't do
No, we
it.
couldn't.
you. Right, thanks very much.
Thank you.
Okay,
Thank you.
Thank you very much.